Hello, everyone. My name is Jun Gong, and I am a medical oncologist at Cedars-Sinai Medical Center. I'd like to greatly thank Zero Prostate Cancer for inviting me to present an update on a jointly funded project by Prostate Cancer Foundation and Zero Prostate Cancer to be presented at the upcoming summit. The project title is a nationwide VA study on systemic treatment patterns in Black patients with metastatic castration-resistant prostate cancer. And a little bit about the background on this project. We all know that prostate cancer racial disparities remain a significant problem, with Black patients historically known to be more than twice as likely to die from prostate cancer compared to white patients. And what we did is, as a backdrop to this project, was we investigated several population level and national registries. And what we saw on this initial data set here was that there was some signals that indeed in the metastatic setting of prostate cancer, certain data registries did identify that Black men with metastatic prostate cancer did poorer than white men receiving systemic therapies. However, if we looked at more prospective registries and those involving clinical trials, what we actually observed was that this gap of this disparities actually narrowed to the point where Black men received systemic therapies and saw similar, if not even better, outcomes than white men receiving systemic therapies for metastatic prostate cancer. And this is really what prompted us to ask this question, which serves the hypothesis of these projects. Why do Black men with metastatic prostate cancer fare worse than white men in population level or national registry data compared to patient level data or clinical trial data? What we can gain from this is that clinical trials may provide all eligible patients enrolled with granted access to agents, timely initiation of cancer therapies. They have strict protocol monitoring and management of side effects, and they follow a strict protocol for adherence to study agents as well. So really what we designed this study was to really ask this question about access. It seems to be very important in the disparities for metastatic prostate cancer patients, but we wanted to isolate this to really to some of the more advanced states of prostate cancer, that known as metastatic castration-resistant prostate cancer, which is prostate cancer states that have been previously treated with hormonal therapy and they have progressed. And what we used is we built this data set with over 10 million veterans from a nationwide Veterans Affairs data set. We really wanted to assess these really non-biological drivers of race that can drive disparities in systemic therapy outcomes between Black and white patients. We designed this into two aims. Aim one was to firstly describe how frequently standard approved metastatic castration-resistant prostate cancer, or MCRPC drugs, are used across Black and white men, and compare these differences in time to initiation of first-line therapy. First line meaning once they are diagnosed with MCRPC, how soon upon this diagnosis are these men started with these life-preserving, prolonging therapies. And then our second aim for this project would be to determine how differences in these treatment patterns affect survival between Black and white men with MCRPC. And so this is really what we've been doing for the first year of this project that's funded by Zero Cancer. Essentially, what we've been doing is we've been building our team at the VA of computer programmers, statisticians, and clinical coordinators to build what we think is going to be one of the largest databases ever available comparing Black and white men. And these, as you can see on the table on the left, we've preliminarily isolated about 39,000 or nearly 40,000 patients that could be eligible for the study, broken down by the types of standard therapies received. And a lot of the first year was really building this database because this is going to be a statistically and numerically a tough data set to evaluate over a short period of time. What we actually use is, in a way, artificial intelligence, AI, to really develop a program to look into the records of all of these veterans from 2000 onwards in the VA system to really collect and abstract the number of men and the types of therapies received. And ultimately, to summarize the project plan, what we're going to do is have our AI computer models abstract this data and really build it into a data set for us in year 2 so that we can design our statistical analysis plan, which is going to be comprising the bulk of our efforts in year 2. This is what we call a statistical analysis plan, where we get together with our statistician team and we look at the data that we've collected from this AI natural language processing model is a specific term for this, where it abstracts key data from the charts, including race, metastases, castration-resistant status, the Gleason score, PSA levels, the type of imaging records, the types of therapies that are received, and the response to these therapies as well. And ultimately, what we hypothesize based on our experience with historical data is that we believe that Black men may have less frequent use of specific prostate cancer drugs, such as abiraterone or enzalutamide, than white counterparts. But if Black men receiving these drugs have similar or improved survival than white men receiving the same drugs before or even after development of MCRPC. The second hypothesis is that Black men experience longer delays to systemic therapy initiation than white men with MCRPC. But again, survival outcomes in Black men are at least similar or better than white men if we can correct for this factor based on our analysis and compare really those that receive the same drug at the same time to initiation of MCRPC therapy. And this is just the kind of the summary of the updates of year 1 so far to this jointly funded project. I'd like to also highlight that we are looking more comprehensively about this access-related question. Really that beyond specific differences in receipt of standard therapies before or after first-line MCRPC could contribute to outcomes in Black men. And we've seen this before in the clinical trial and prospective registries that they do have equivalent better outcomes actually. We like the use of the equal access VA health system because this really ensures that what we're comparing is an even playing field, allow for study of non-biological factors of race that can drive disparities in MCRPC treatment outcomes. A little bit of a side, another additional project that we're doing as well. This is through a separate project, we're actually developing another data set to determine drug compliance among Black and white men with MCRPC. So here with the Zero Prostate Cancer and Prostate Cancer Foundation project, we're looking at access, receipt of first-line therapies, and the time to initiation. Another key component is, what about compliance? When you are given and prescribed medications, does compliance play a role in these differences? And this is what the other project is studying, is drug compliance. And we hypothesize that if drug compliance is accounted for as well, this again contributes to equal, if not better, outcomes for Black men compared to white men with CRPC. And so on that note, I'd like to greatly thank the Zero Prostate Cancer and Prostate Cancer Foundation for funding this very important project. And we look forward to presenting more updates on this in the future.